Good afternoon and welcome to the May webinar presented by the Recruitment, Training and Support Center at the Federation for Children with Special Needs. My name is Paige Parisi and I am the Program Director for RTSC. Our program today will have a slightly different format than we've used in the past. Janie Kreco, our Training and Support Specialist, will be interviewing Darcy Rubino about the Massachusetts Children's Behavioral Health Initiative, CBHI. Darcy is a health information specialist with the Mass Family Voices Family-to-Family Health Information Center here at the Federation. Darcy has also been a CBHI family partner at the K-Band Salem CSA and a LEND Family Fellow at Boston Children's Hospital. Our technology producers today are Emily Gaudette and John Sullivan. If you are interested in learning more about the Federation, please go to our website at fcsn.org. and explore all the different programs, including the Special Education Surrogate Parent Program, which sponsors these webinars. Our webinar today is being recorded and will be available on the RTSC website under the link Resources for Everyone. During the webinar, please type your questions in the toolbox and feel free to engage with one another as appropriate. I will monitor the questions as they come in and, to the extent time allows, discuss them with Darcy and Janie. If your question is not answered live, please send us an email and we will do our best to follow up with you. Janie?
Hello everyone, and welcome to our May webinar. So our topics of discussion today are going to include an explanation of what the CBHI is, who's eligible, what services people can access, how do you get started? That's always a tough question. How you can integrate CBHI services into schools and also into foster care and congregate settings. So I'll be introducing the topics and Darcy will be explaining them to us. Thank you for being here, Darcy.
No problem.
So the big question, what exactly is CBHI?
Well, CBHI, or Children's Behavioral Health Initiative, is basically an initiative of the Commonwealth's Executive Office of Health and Human Services. So it can meet the needs of children and youth in Massachusetts who have serious emotional disturbance, or SED, and their families. Called the CD Massachusetts to provide intensive home gain over 15,000 Medicare. So there are different kinds of Mass Health for children with behavioral health issues. The first is Mass Health Standard, and the second is Mass Health Common Health. Mass Health Standard is most commonly associated with as well as SSI, and basically it is a second insurance to a primary insurance that the parent or guardian might purchase through their employer. And there are also different health providers in Mass Health, known as Managed Care Entities, or MCEs. Examples of these providers are Health New England, Fallon Plan, Neighborhood Health Plan, Beacon Health Strategies, and So the CBHI mission is to strengthen and expand and integrate Massachusetts state services into a comprehensive and community-based system of care that ensures families and their children with significant behavioral, emotional, and mental health needs obtain the services necessary for success across all domains in home, school, and community.
Thank you, Darcy. Can you tell us who's eligible for Mass Health? I know that that could be a question that a lot of people have.
Sure. So basically, to be eligible for Mass Health, you could be eligible based for Mass Health Standard, which is low or no income, like I said, or SSI eligible. Also, you can be eligible for Mass Health based on disability, and that would be the Common Health. For CBHI services, you have to be under 21 years old and have what's called a serious emotional disturbance, like I said, SED, or a behavioral health diagnosis. And you also have to have a medical necessity of the services that CBHI offers. Basically, medical necessity refers to why the service is needed. And each CBHI service has a different medical necessity criteria, but in general it has to do with the use identified diagnosis disorder that basically results in some sort of functional impairment that substantially interferes with or limits the use, role, or functioning in the family, school, or community activities.
I know we have a full menu of services available through CBHI, and so what I'm going to do is just go through them slowly and let you explain to the audience exactly what each level of service entails.
Sure. So intensive care coordination, or ICC as it is frequently called, helps bring together the main supports in your child's life so that everyone is working together to help the child. The family or guardian chooses who is on the team, and it can include professionals like therapists, social workers, or teachers, and also natural supports like friends or relatives. It's good to note that the child can have their friends on the team as well, because it's very helpful to really have someone up here on the team with you. In-home therapy basically would be appropriate if the youth behavior is making daily life hard for the family. Clinicians will work with the whole family and help the parent help their child. In-home therapy can help to resolve conflicts, learn new ways of doing things, make new routines, or set limits. So in-home behavioral services is different from in-home therapy. In-home behavioral therapy basically is if you have a child who sometimes will do something over and over that bothers other people or harms the child. If it's hard to get the child to act differently, a therapist will work with you and others in your child's life to try new ways to help your child to change these behaviors. Family support and training, or family partners, are people that help parents and caregivers help their children reach their treatment goals. Their parents are caregivers of children with special needs, and they've been there. They understand what families go through and can share their experiences. Family partners are not behavioral health professionals, but work closely with parents to help them get the services and supports their children need. So therapeutic mentoring. Some children want to get along with others but need help in practice, learning to talk or act in new ways. A therapeutic mentor will go with your child to the places where your child has the most trouble and teach him or her new skills, like a better way to talk to someone or act around peers or adults. So mobile crisis intervention can be utilized when your child is having a crisis and needs help right away. Mobile crisis can also meet with the family, other providers, or school, whoever the family chooses to, basically, before a crisis even occurs in order to assist with safety planning and crisis prevention. Mobile crisis is available 24 hours a day, 7 days a week. A trained team will come to your home, school, or other place in the community to help your child with the crisis. The team will also help you get other services for your family.
So these are wonderful services, and I think we understand now who is eligible. But if I have a child, or if I know of a child who would benefit from CBHI services, Can you explain to us how you would get started? I know it's a big system, and there are a lot of people out there that can give help, including your program that you work for at the Federation. But if you could explain it in a way that we can all understand would be great.
Sure. So if a child already has MassHealth, they would want to first make sure that they are hooked up with one of those managed care entities that I just mentioned, the list that I went through, because even though they have MassHealth, they have to actually sign up for a managed care entity. Even if they have Common Health and they can only have MBHP or Mass Behavioral Health Partnership, they still have to make that call. Mass Family Voices, our project, can give you the phone number, or you could probably find it on the MassHealth website. So basically, parents or guardians would want to call providers or agencies directly. I think we provided a list of CSAs beforehand, or after, sorry. And they're regional, so you'll be able to figure out what agencies service your area. You can call and make a referral. If the youth already has an outpatient clinician, you can talk to them about what services might be appropriate, you know, mentoring, do they need care coordination, do they need someone in the home? And you can also call MassHealth Customer Service or go on the mabhageaccess.com website. So if they're not currently using behavioral health services through MassHealth, again, you still would want to call one of the managed care entities to make sure they're signed up. Parents can still call providers directly. Sometimes if you're not sure what to do, call the agency in your area. They'll tell you. They'll tell you what they need from you before your child can enroll in services. Talk to your primary care doctor or a nurse. Pediatricians are a great wealth of knowledge about local supports in the area, especially now where the medical home is such a big push. A lot of primary care providers have clinicians in their practice. And again, you can call MassHealth Customer Service.
Okay, Darcy, thank you so much. I guess there was an audio problem when we first started, so we're going to repeat the information about the two kinds of MassHealth and the different providers.
Oh, okay.
And let me just go back myself here to that slide so that we can explain to people. Oops, I went too far. Where is it? It's before that? I apologize for this.
Technical difficulties.
Oh, there's the types of MassHealth. Yeah. Okay. So if you could go through that again, Darcy.
Sure. So there's two types of MassHealth: MassHealth Standard and MassHealth Common Health. MassHealth Standard is normally for low or no income families or children who get SSI. They're SSI eligible. And then MassHealth Common Health is where you have MassHealth as a secondary insurance to a primary insurance that you might get through a provider. And they will pick up co-pays and different things as long as your primary insurance also covers those services as well.
And can you tell us about those different health providers, which
Sure.
Can be very confusing
Absolutely.
for people?
So like Janie said, there are different health providers known as managed care entities, or you might hear them referred to as MCEs. In Massachusetts, some of these providers are Health New England, Fallon Community Health Plan, Neighborhood Health Plan, BMC HealthNet, Beacon Health Strategies, or the Mass Behavioral Health Partnerships, better known as MBHP. So if you are a Common Health, if you have Common Health, the only MCE or managed care entity you can have for behavioral health is the Mass Behavioral Health Partnership, MBHP. So even though that is the only one you can have, you still have to call them and sign up to make sure that you are on their service and to make sure that all the services fall in line.
Okay, I hope everybody gets that. It's confusing. When I worked in the community, I know that it was confusing to me, and I was in the middle of the
Absolutely.
system. So, all right, I'm going to scroll forward here back to where we were, so that Darcy can continue talking to us about This very important services. Oh yeah. So now we're going to talk about those community service agencies, CSAs, and you mentioned them before, and how they actually kind of coordinate all the services through the CBHI.
Sure. So a CSA, like Jeannie said, is a community service agency, and they're set up as a community-based organization whose function is to really facilitate access to and ensure coordination of care for youth with serious emotional disturbance who require or are already utilizing multiple services or involved with multiple child-serving systems like DCF, special education, juvenile justice, and their families. The CSA houses, the Community Service Agency houses the ICC, the Intensive Care Coordinator, and the family partner. Where it gets confusing is that same agency might also have in-home therapy services or outpatient services. So you always just want to kind of clarify when you're calling which department or what they do for their job there, so you're making the right referral.
That's a very good good suggestion, is to clarify who you're speaking to, or whom you're speaking to, and what you're talking about, because it's a big, big service.
Absolutely.
And very confusing. As Darcy mentioned before, we do have a list of the regional CSAs, the regional community service agencies. We did not send them out before the PowerPoint, before the webinar, but we will be sending it out right afterwards. So be looking for that in your email. It's a very valuable source of information for everyone, families and service agencies also. Okay, so next, CBHI within the schools. This is something that I know a lot of the people on the webinar are interested in, the school personnel, so let's tell them what it's all about.
Sure. So schools can really be an active part of the intensive care coordination team as long as the parent invites them to be. CBHI is really all about family voice and choice. So families determine team members, families determine goals. So if it can be super helpful for schools to be involved in that process because treatment goals can be supported during the day or throughout the IEP. Many care plan team meetings will be held at the school every couple of months so that the home team can make sure they are on the same page as the school team. The care plan team meeting is a time for all members to check in on progress towards goals, as well as a chance to figure out what's working and what's not working. It's also a good time for crisis and safety planning. It's a great way to include schools and CBHI providers before there's an actual crisis. And then they can plan for what's going to happen in school and at home if something is going on.
So the Department of Special Ed actually came out with an advisory recently. It's dated March 10th, 2014. It is on our list of references at the end of the PowerPoint, but it really talks about the school piece in the CBHI, and it's, I think, extremely well written, very user-friendly, and it does talk about that collaboration between CBHI and schools. And one of the things that it does talk a bit about is the mobile crisis intervention. Can you speak a little bit more about that in the schools?
Sure. So it's always a good choice for schools to contact the parent or guardian before they call mobile crisis intervention. So basically, a child would be having a really hard time in class, in school, acting out, kind of escalating to a crisis situation. School personnel should be calling mom, dad, foster parent, whatever, guardian, and to tell them about what's going on and to collaborate to figure out what the best thing is to do. So if parents or guardians decide with school that mobile crisis should be called, they can call mobile crisis. Mobile crisis should be able to come out to the school and do an assessment of the youth and screen them for kind of a mental health crisis and determine, okay, do they just need to make a safety plan? Do they need a higher level of care? What do they need right now? And that's a great way for parents, guardians, and school to collaborate in this CBHI world. They're going to need mobile crisis is definitely going to need a quiet space to meet with the child. And like I talked about before, increasing success by pre-planning what is going on. So if you know a child is triggered by different things, plan beforehand and let them know. Because what happens in CBHI is that there is a safety plan that ICCs, intensive care coordinators, get, that in-home behavioral clinicians get, as well as mobile crisis. Those plans are the same for everybody. So it's good for the school to have a copy of that plan and to be built into that plan.
So a couple of questions have come through that I want to talk a little bit about. One of them, and I think I know the answer to this, but I'll let you answer it. Can mobile crisis refuse to come to a school if the child is too dangerous? And who makes that call about the dangerousness of the child?
If it is a safety issue, mobile crisis most likely will not come out, and they will tell you that you probably need to call 911. It could be the clinician that is making, the mobile crisis clinician that's making that determination. It could be the director of mobile crisis. It really just depends. If a safety issue really should be going through 911. It's hard though, because usually safety issues are stemming from kind of a mental health crisis point.
I believe I read in one of our brochures here on CBHI that the school itself can decide to call 911 along with calling mobile crisis if they feel that the child is unsafe for themselves or others.
I would say yes, but again, I would encourage all school staff to definitely collaborate with the parents before any. Of course, obviously, if it's a real safety medical issue, call 911. But at any point, if it's to collaborate with the parents is always the best thing.
I like that. Good. Okay, so another question is asked about whether there has to be an FBA in place for crisis or for CBH to be involved. I have not heard that.
No. Well, so I'm guessing. So in-home behavioral services or in-home behavioral therapy is basically where a functional behavioral assessment and FBA might come into play. What there is for, and I think we're going to go through each one of these, the services, but basically there's a team of two, a monitor, which is a paraprofessional, and a clinician that will do a functional behavioral assessment in the home. But you don't need an FBA to access any of these services at all.
Okay, so let's talk a little bit about collaboration with IEP planning.
Sure.
And again, the advisory that came out in March talks a lot about this collaboration and how CBHI can be so appropriate for IEP planning and vice versa.
Right.
So talk a little bit about that, and we will talk about the system of care meetings, which we haven't introduced yet. And I'll just give a little case study from the advisory after you're done.
Sure. Okay. So CBHI providers can work really great in tandem to create safety plans that span across the domains of the youth life. Also, if a youth utilizes in-home behavioral therapy, which I just spoke of, and has had a functional behavioral assessment done by the school, comparing notes and strategies around behavior planning is crucial to, I think collaboration is crucial to any child's success, specifically, children in this situation. CBHI providers are welcome to attend any school or IEP meeting if invited by the parent or guardian. They're often able to give insight into how the youth is functioning at home and in the community that sometimes school professionals won't have. Because they just see them during the day, and they don't really get to see what happens to Johnny after 3 o'clock. So another thing is we talked about system of care. So part of the Rosie D. lawsuit set in place a monthly system of care meeting where the stakeholders in the community really discuss what's happening with youth and mental health in that community. It's important to have families represented at this meeting as well as school professionals. They occur every month, usually run through the local CSA. I encourage, if you are a school staff member, to attend one. I encourage, if you are a parent or a foster parent, to attend one. Usually there's different topics. You know, sometimes they're talking about resources, sometimes they're talking about substance abuse, sometimes they're talking about trauma and learning, lots of different things, you know. So they're a really great way to meet stakeholders in your community as well.
Thanks, Darcy. Oops, I'm hoping people heard me, but I said thank you. But the attendance at IEP meetings, I know that when I was working in the community as a in-home therapist, I attended a lot of IEP meetings for the kids that or the families I was working with. I was always there by, because the families had invited me and the schools were aware that I was coming. I thought that was a great way to collaborate. So just elaborate a little bit on that. It doesn't just have to be the in-home therapist. It could be the other professionals.
No, and I think what you just said is, as long as the schools know you're coming, I think it's always courteous to let your school district know who you're going to be bringing with you. So anyone can, if a parent thinks their neighbor is a good person to be there just because they're a great natural support. The therapeutic mentor can, I've seen therapeutic mentors go a lot. Family partners, clinicians, outpatient clinicians, in-home behavioral clinicians, in-home therapists. All of those people, if invited by the parent, should be welcomed at IEP meetings or check-in meetings. I just think it's only beneficial to the child, because these are all the people that are supporting this family and that child to reach goals and to do better. And what a better way to have everybody at the table.
Yes, and I think that the more the merrier for some of these kids with their challenging behaviors. Anybody who can bring some new ideas or more insights into the team meeting. It's very good. So the little, let me just give you the little case study that they talked about in the advisory. It's a little guy named David, the in-home behavioral therapist arranged to observe the boy in the classroom and to review the plans in place to support him. So this was somebody who was working, behaviorist who was working in the home, was asked by the parent, and I'm assuming also the school, to observe the child's behaviors in the classroom. And the behaviorist reviewed the plans in place to support him. And then she presented a report to the IEP team and discussed her insights into the clinical and behavioral issues impacting the boy's success and access to the curriculum. And the interesting part about the end of this case study was that the team agreed, the IEP team agreed to have her consult with the classroom staff as part of David's IEP. So ultimate collaboration there.
Absolutely.
Professionals are going between home and school, and I always say these kids' problems don't end when the bell rings. And so to have someone who works between the two services is awesome.
And I really commend that school district for being so open and accepting. Because I really think that's very important.
One of the things that we're not going to touch on a whole lot is the fact that schools have the ability to bill Mass Health for a lot of the services that they are offering. And it's all based on the school-based Medicaid SBM claims, which I'm sure the school professionals out there will understand. And it is in the guide for school personnel, which came out in October 2011, and again, that is one of our references at the end of the webinar. So if anybody is interested, just link on the hyperlink that we have and go ahead and see how that a lot of the services are billable that schools are doing, which involves CBHI.
And again, the parents have to sign off on that.
Absolutely, and that's a big part of the Medicaid.
Right.
Okay, so a couple of curious questions. Can a child without a diagnosis or who is not receiving either Mass Health or CBHI access mobile crisis?
The model is yes, that they can. It depends per agency, I believe. It depends on if they accept all insurances or just Mass Health. I personally, we've gone through the situation where my daughter didn't have Mass Health and we saw mobile crisis, but that's just one agency. Yes.
I know that's always a question,
Right.
and I believe you're right. I think that they tried to open mobile crisis up to all kids,
Absolutely.
especially at school.
Right.
So the other question is kind of a more specific question about if a child is refusing school, school refusal, a very complicated clinical problem. Can mobile crisis intervene at the home to help that?
I probably wouldn't start with mobile crisis. I would have to say that in that situation, that should be a goal. Well, first, I would hope that the parents or guardians try to get care coordination services or in-home therapy services, because those can be goals. And I've seen lots of providers, ICCs and in-home clinicians, they come to the house at 7:30 in the morning, and that's part of the transition, and that's one of the goals that they work on. And they really do everything they can to support the child if that is a goal outlined in a care plan.
Okay, so thank you very much, and I'm sure we'll have more questions coming through on the school questions. But can you talk a little bit about the behavioral health and public schools framework and how CBHI can work with the schools on accessing that framework for these kids?
Sure. So the Behavioral Health in Public Schools framework was designed to promote supportive whole school environments and to work with CSAs and families with CBHI services so that they can assist with goals in school and achieving the framework's goals.
So I know that the framework was put together according to the anti-bullying legislation, and I do believe we have a reference to this at the end of the webinar. Do we have a reference? Yes. Okay. So people can go on and online and see this. A lot of people don't know this exists,
Right.
And it's actually very well written.
And it's sometimes hard to find, and I think that's
part of the problem is that it might be hard to find, but we have a link, so go ahead on. It also has to do with the social emotional learning curriculum, which is attached to this also. So it's kind of a nice big package of behavioral health stuff. So please do go on and take a look at that if you're working at a school. Alrighty, so I think that now it's my turn to talk a little bit about foster care and CBHI, and this would be specifically for our foster parents that are listening or our special education surrogate parents. There is an actual guide that kind of gives a really good picture of this, and it was put out by the Department of Children and Families. And it's the Guide to New and Current Mass Health Behavioral Health Services. And again, this was written right at the beginning of CBHI. So I remember attending lots of meetings about this and how everybody was so excited. But it is still out there, and it can be accessed. Again, we do have that as our references. But essentially what it's about is that foster care or kids in congregate care, actually, but we'll talk about that second, can access CBHI services in their foster home. And that will bring in collaboration with the school and the wonderful support from the intensive care coordination teams, whom I loved working with. I think they took so much of a burden off of the family and off of me as the home therapist, because they could coordinate all of the other services involved, including DCF. And we met on a monthly basis, and everybody caught up about everything, and it was just wonderful. So I would strongly encourage any foster families out there who are not accessing CBHI services to find out about them immediately, either from their social worker from DCF or from you guys at Family Voices here at the Federation, or to call or to discuss it with their pediatrician or therapist that might be a clinical therapist in a clinic somewhere. The other thing that's great about CBHI in foster care is the crisis management, because CBHI, the first thing we always did was set up the crisis plan, the safety plan. And kids in foster care tend to be very reactive, and sometimes can be difficult when they are triggered. And so having the crisis team on board is wonderful because they have, as you had said, they have the plan, the family has the plan, the therapist has the plan, and we can kind of have it go into place immediately should a kid decompensate or have a crisis. It's also a great way to prepare the child for reentry into the community or back into the foster home after a psychiatric placement. And we all know that kids with behavioral health issues do go in and out of various levels of care, psychiatric care, including, they all have little acronyms, but some of them go from 3 to 5 days to several weeks. But for a kid to transition back home to a foster care placement after that psychiatric placement, it's great to have CBHI involved because, again, they can do that collaboration and everybody can be on board. And the schools can be informed also through CBHI that the child is coming and going and be prepared for their reentry into school. Step downs from congregate care. It's a little bit more difficult to access, I would say. Is that true, Darcy?
Yes.
Because of the fact that the system is not as routinized as we probably would need it to be to access these services. There's a specific number of days, which is 180. So in order for someone to access CBHI from a congregate placement, we would have to have a discharge placement no more than 6 months out.
Right, there has to be a date.
There has to be a date, and CBHI could then go start to work in the community or with the foster family or the pre-adoptive family around getting ready to bring this child home from congregate care, which is either residential, group home, or whatever. Right. It's a great way to make sure that things are in place and transitioning well when a child is coming out of congregate care. Something I didn't realize, and thank you for telling me, Darcy, was that you can also work with kids that are aging out of the child welfare system for reunification and reintegration back into their home community at 18. So I'm going to let you talk a little bit about that and the deadlines. I think the deadlines are the same, the 180 days, if I'm not mistaken.
Well, so I would first say that CBHI services are eligible for children or adults up until the age of 21. So if at 18 a child is no longer in the DCF system, they still have access to, the menu of services that CBHI offers if they want to partake. So that is great, and I think that it could be really a great foundation for stabilization into their adult life. Care coordination would be great. I know a lot of care coordinators I've worked with, they've brought in like a mass rehab to work with the youth, on getting skills for working and just kind of getting into the community and being independent. I think it's fantastic that CBHI goes up until age 21.
So if a kid is aging out and does not want to stay in DCF, so they've signed themselves out at 18, but they do still want to reunify with kinship or family, can they themselves request CBHI services for themselves?
Absolutely. They're their own guardian, so they can pretty much do whatever they want. And the good part about CBHI is that a major component of it is accessing community resources and supports. So they're those family partner or care coordinator are going to help the youth reach the goals that they want. And if their goal is to get back with biological family members, then they'll do that. If their goal is to find a job or go to school, they're going to help them do that and facilitate that.
Okay, so we are now talking. We did talk about this already. Obviously, this is about transitions, and it's so important for kids, not only with behavioral health challenges, but for kids that are coming out of the child welfare system who don't have a lot of family support.
Right.
So I think it's great that CBHI is out there for them. Let's see. I think as far as what we have to interview you about, we're at the end, but I know there's a bunch of questions here.
I think we just got a request to go for myself to go over the Rosie D stuff again, so I'm just gonna read that again if that's okay. So the Children's Behavioral Health Initiative was brought about because of a class action lawsuit that was brought under the EPSDT, which is the Early Periodic Screening, Diagnosis, and Treatment Program. Provisions of the Medicaid Act to compel Massachusetts to provide intensive home-based mental health services that will enable children with severe emotional disturbances to receive treatment and support in their homes and their communities. The plaintiffs include 8 named children and a class of over 15,000 other Medicaid recipients through the Commonwealth with serious psychiatric and emotional disabilities. I just wanted to say with that too is that the reason CBHI exists, besides this lawsuit, is to keep children and youth in the communities, to keep them out of emergency rooms, to keep them out of psychiatric hospitalizations. So everything is community-based. You know, meetings are occurring in the home, in the school, in the community. You know, not necessarily in an office, but it can be whatever the family or youth want. But I think that really pointing out that this is a way to keep youth successful and in the community is really a good point to kind of hammer home.
And I like their mantra, family
voice and choice.
Family voice, family choice, and it's extremely family strength based.
Right. Yeah. And it goes along with the nothing about me without me.
I never heard that one. I like that. Say that again.
Nothing about me without me.
Very nice. Okay. So another question that came in, and I'll answer this because it has to do with congregate and foster care, unless I need your help here. Okay. So if a child is in foster care or congregate care and is escalating and assaultive, like that will never happen, will mobile crisis go out to evaluate and help manage the crisis? I think the answer you gave at the school goes the same for this. I think it's a call on the part of the staff where the child might be in congregate care as to whether or not it's a 911 call or a crisis call, and that's always going to be kind of a call from the gut as to whether it can be handled by mobile crisis or it has to be a 911 because of the seriousness of the danger factor.
But mobile crisis definitely goes out to, you know, CBATS, which is a community-based acute treatment center, because those are not locked units. Those are open units. And so if a youth is really escalating and for safety needs to be, you know, reach a higher level of care, you call mobile crisis in, and they're the ones that actually make the calls to hospital and get insurance set up.
And on the other hand, if the child is in foster care, again, not as easy a call because it'll be the foster parent who has to decide whether or not they're dangerously escalating. But I think every foster mom or father should have on their speed dial mobile crisis,
or magnet on the refrigerator,
or and also, you know, if it's a child who does have a parent and is in programmatic care, to get those parents involved immediately, or social worker, of course.
Right, absolutely.
So, you know, there's a couple of people that have to be involved in any of this. I think the only time when it would override any of this is if the kid was highly homicidal or suicidal.
Yes.
Then 911 would be called immediately.
Absolutely.
One of the things that I read last night, which was interesting, is the use of restraint. And just so people understand, mobile crisis teams may not use restraints. Is that right?
As far as I know, I don't know anything specific to that. I would say yes, that's true.
And I think that's probably a good rule. So that means that you can't expect a mobile crisis team to come into your home or into the school and expect them to restrain the child. No. Someone has to be trained, highly trained in schools these days to restrain a child. And I believe in foster homes you can never restrain a child. So there's that limitation too that might make the call to 911 a better choice than to crisis management. So, yes. Any other questions, Paige?
Talk about the timing of mobile crisis, how it's different from 911 and their reaction time.
Sure. So timing around mobile crisis. So a person would make a call to mobile crisis and they would do an intake just like any kind of other referral, and they would get your name, the name of the child, where you are, what is happening, did something, happen before, was it a trigger, what are they doing? And like any agency or job, they could be out on other calls. So they could say a number of things. They could say, okay, well, we can meet you in a couple of hours, or I think that is, or 1 hour. They're supposed to see you within 1 hour. So they could say we can be out there in 1 hour, but they also may say we'll meet you at the emergency room if it's more emergent. It's supposed to be 1 hour. We'll just leave it at that.
And the difference between that and 911, if you call 911.
They come right away.
They come right away.
Right.
And sometimes that's the compelling difference.
Right.
And even 1 hour for a child in crisis can be very difficult.
Well, and it also could be that, they can just be, I've worked with many families where the family has called mobile crisis and all the child needed was to talk to a clinician over the phone to kind of de-escalate them and come up with a strategy. And that has worked really well, and they don't have to go anywhere, and they don't have to be screened.
And that should all be part of the safety plan.
Absolutely.
So I think we should reiterate that once you become a member of CBHI, and it's child-directed, the child is always the client, that the crisis management team will, with the actual care team, produce a crisis plan or safety plan.
The safety plan should be made at that very first appointment.
Right, exactly.
At the intake.
Yes.
And that is, the protocol is to share that with mobile crisis in your area.
Right, and now it used to be that mobile crisis was the one responsible for disseminating that plan among other providers. Now I'm thinking if there's an intensive care coordinator involved, they would be the ones to disseminate that plan.
Right, so, and I don't think we talked about that kind of hierarchy of care. So there are 3 levels of care, and the highest level of care is to have an intensive care coordinator or an ICC. Secondary to that is the in-home therapy, and last would be an outpatient clinician. So whoever is the highest level of care is responsible for getting that safety plan and first of all, creating that safety plan and getting it to mobile crisis.
And also, one of the things that schools are cautioned to do is to have a liaison who's able to immediately be accessible for a child who might be in behavioral health crisis, so that they can work with the providers and to access the safety plans and to access mobile crisis, so that people, when a child's in crisis, it gets very chaotic very quickly. But if there's somebody assigned to the task within the school to be that liaison with CBHI, it's very helpful, and things can happen in very quick sequence.
I would even say have that staff member be proactive and ask for the safety plan, just so that everyone has the same safety plan, and make sure, if you are a parent or a guardian or a teacher or what have you, make sure that school is on that safety plan. What happens at school? A lot of people just think of the safety plan for what's going to happen in the community or at home, but have school built into that safety plan so that everybody knows what's going on with that child and what they're supposed to do and who's supposed to do it.
And I think about IEP collaboration because that's my thing.
That is your thing.
Yeah, so, you know, to have some of these, certainly have the safety plan as a part of the IEP and additional information.
Right. I would always suggest additional information as much as the parent or guardian wants listed in there. You know, CBHI services are in place, the child has a therapeutic mentor, the safety plan, safety plan addendum, anything like that.
And also to actually maybe think about writing goals from the input from all of the people involved with the CBHI services about how to de-escalate, about how to improve behavioral health goals that might be in the IEP.
And that's good for special education surrogate parents because they're helping with the IEP. So for them to be involved in a, you know, in an IEP meeting and kind of, so if the only way it would happen is if the child is transitioning out of, because when you have a special education surrogate parent, it's because DCF is has custody, correct?
Yes.
So it would be a child who is transitioning out of that into maybe a foster home. So you would want to make sure that foster parent and the special education surrogate parent plus CBHI are all on the same page and are talking about that big transition.
Yes, and just so we all know, Darcy is an SESP.
Yes, I am.
And we're so proud of her for that. Yes, but sometimes SESPs continue to work with the foster families once the child is placed. So that's another nice transition.
Well, it's a good thing because they're volunteers, so they're happy to help, I think.
Yes, that's right. Exactly. So I think we've got another question coming up on page.
Are there services for siblings and parents, like respite, support groups for siblings, CBHI, or?
So specifically not, oh sure. So the question was, are there supports or groups for siblings through CBHI? So siblings without a diagnosis, not specifically, but, and you said respite too, as the respite. So the way it works is a lot of these agencies have these groups set up. A lot of them also do, and this is probably going to confuse everyone. So DMH contracts with agencies to do single service coverage for children who meet the DMH diagnostic criteria. So lots of agencies have groups every week. They have, you know, groups over vacation. They have, you know, so say there's a Lego group or there's like a social skills group, and those are funded by DMH and vary definitely throughout the state depending on your agency and DMH, how they're working together and staffing. But the agency might have a support group for siblings. Definitely. Respite usually comes through DMH, and that could be single service as well. But to access that, you have to have intensive care coordination. You can't just have in-home therapy and access it. You have to have intensive care coordination to access those single service DMH offerings.
So in order to be eligible, I'm just going to reiterate this and make sure that I have this right. In order to be eligible for the Department of Mental Health single services, like groups or camps or things like that, you have to be enrolled in CBHI at the highest level of care.
Right. So you have to have ICC, intensive care coordination, definitely. So, and I alluded to siblings without diagnoses. So if a sibling has so oftentimes there are two children that are struggling in the home, and they can be opened under the same exact team or a different team, whatever is convenient for the parent or guardian. And definitely siblings can be worked into care plans because that's supporting of the parent. And, you know, because I think about family partner goals, and their goals are mainly around parent education, community resources and supports, and like coaching of parenting skills. And so if a sibling is struggling, that definitely can be built into care plans.
We didn't talk too much about individualized or
individual care plans.
Individual care plans. Yes. Maybe you should speak a little bit about that. Who writes them?
Sure.
At what level of care?
So an ICP, or an individual care plan, is basically everything about the child and all the goals that have been kind of brainstormed. So what would happen is, so if you're going to enroll in ICC Intensive Care Coordination Services, you're going to have a care plan team meeting within 28 days. Within that 28 days, you'll have the meeting. You invite everybody you want to the meeting who is really a part of the team that is going to help the child. And everybody at that table is going to brainstorm ideas and goals. And then mom, dad, guardian, caretaker are going to say yes to that goal, no to that goal. It's up to them. Again, family voice and choice. So the care plan is going to outline what the goal is, who is going to help with the goal, and as it progresses every month or every 6 weeks, you're going to have another care plan meeting. And so it's going to say, you know, say Johnny's goal is to have less tantrums doing homework. So who's going to help? Mom and dad's going to help. Maybe in-home therapy is going to help because they're going to be there. Maybe therapeutic mentor. And it's going to say, it's going to be updated at the end of every meeting. And it's going to say met, ongoing. And the person who writes that care plan is the intensive care coordinator, the ICC.
We have school goals on that.
Absolutely. You can have whatever goals you want, you know, and it depends on, I think more that would come into question is who's going to work on the goals. Like I would hope that school staff would be, you know, more than willing to help work on goals. And probably their IEP goals are very much aligned to the goals that are going to be outlined in the care plan.
And I know that that's billable for schools if they do attend those meetings. So if
the parent has signed off on the Medicaid.
Exactly. Right. So it's all about the Medicaid law,
right?
Which I'm not that well versed in, but I know exists.
Right.
Okay. Anything else, Paige? I think we're good. Okay, great. Well, what I'm showing now is an actual chart that has been produced by CBHI. It's a little fuzzy on my machine, but it is available. You can kind of, probably if you blow it up, you can read it better. And there's our references at the end. And please go online and get more information as you need. And thank you very much. We will send out a Survey Monkey. And if you have any additional questions, you can certainly email RTSC. That would probably go to me or Paige. And Darcy's address, I believe, was at the beginning of these slides. So.
Or you can call Mass Family Voices if you have questions specific to Mass Health at 1-800-331-0688, extension 301.
Okay, great. Thank you so much for being with us.
Oh, thank you.
Alrighty. Bye.